to you how to ace the Viva exam and what the examiners really want to hear from you in 2B exam. So over to you, Dr. Mita, and candidate number 1, please.
Yeah, before starting the vivas, I will take 5 minutes to just give a brief idea about the exam and exam in my way and in the way of Royal College, what they want and what they need, so that we can moving ahead from that. All right. So why this 2B exam Viva structure existed? The reason behind that is there are two systems in UK radiology practice. One is duty and another is MDT session. During duty session, what happens is radiology is there on the command center, or you can say that in the central room, where various people call them and ask them about the emergency cases, what could be the findings, and what to do next. So basically, the radiologist needs to be up to date to have a look at the scan and to give the opinion systematically and properly. So that's why that kind of the cases will be asked in the Viva, also known as the safety cases, which you can't miss it. Another thing is MDT. That is very important part of the NHS structure.
Recording in progress.
Multidisciplinary team meeting. In that multidisciplinary team meeting, what happens is that you need to take consideration towards the various clinical pathway. So there will be a clinical question and you need to direct towards the some clinical pathway. For example, patient has some abdominal pain. Now you have to develop some findings and divert it towards maybe surgical pathway, maybe medical pathway, maybe vascular pathway, something like that. So that's why this Viva structure exists. And they want that kind of the findings only. So whenever you are giving Viva, you need to be systematic. They want you to be a systematic approach, which includes observation, interpretation, differential diagnosis, and management. This should be the structure whenever you are speaking. And there are certain things which you need to take care of. You don't need to be a scattergun approach, means you don't need to speak lot of things, lot of diagnosis. They will deduct your marks. You are not allowed to miss any safety finding. You need to develop a habit to go ahead with the safety finding. You have to check them. And always, last and not the least thing is that you have to follow a structured approach. And finally, you need to conclude your Viva with the management. So these are important things. And another thing is, whenever you are giving answers, whenever you are look at this screen, first, always observe the case, take the time, tell the examiner that I will have a few minutes to look at the case, and then start your Viva. That will create a better impression that you are not hefty, you are a safe radiologist. So main aim is to become a safe radiologist. And that's why this exam structure has been in place. So now we are starting with candidate 1. Who is candidate 1? Are you here?
Good evening, sir. Yes, I'm here.
Okay. What I will do is I will share my screen, and whenever there is a need, I will ask you to take a control. Okay. Otherwise, you don't need to take a control. Whenever you feel that the things are not clear, you can ask me to zoom in, zoom out, something like that. All right. So I'm
Okay, sir.
sharing my screen here, and then we are moving ahead from that. So candidate 1, this is first case for you, and you can take it over. So the first case, I would like to give you a bit of clinical detail for that. Every case will be having clinical detail, and then we will move ahead. A child present with a right-sided limp. Please go ahead, candidate 1.
This is X-ray pelvis frontal projection in a pediatric age group patient who presented with limp. In this X-ray, I can appreciate that there is the decreased height of right femoral head. There are also some prominent subchondral lucencies seen on the right side. And if I further see it on detail, the epiphyseal and metaphyseal junctional region is showing a bit of sclerosis and loss of growth plate. The acetabular roof is showing sclerosis as well, along with some irregularities in its margin. There are few loose bodies seen, foci of calcification, you can say, within the joint space. I believe that this is a long-standing process, not very acute. The associated fat planes are not blurred. There is no significant swelling. Although if compared to the left side, there is a bit more swelling in the soft tissue on this side, but doesn't look severely distorted. If I come towards the left side, I can appreciate that there is a bit of irregularity on that side in the medialmost part of the femoral head, but the height is maintained and the joint integrity is maintained. The right side, I would like to comment on one more thing, that there is some angular deformity in the neck of the region as well. I would like to take the history if the patient, this is the first time presentation of the patient, or if there are previous films as well, because in that scenario, I would like to compare with the previous one to see the progression of the disease. It looks like a case of avascular necrosis with degenerative changes. And if the patient has the MRI has not been done before, next I would like to see the MRI. So my diagnosis based on this case is Perthes disease with secondary degenerative changes and some deformity of the femoral neck. And next, I would also like to see the previous film and advise MRI for further management.
All right. So what we'll do is we are taking cases first, and then in the end we will discuss them. Okay. Yeah.
Okay.
Second case, and for that you might be needing control. So if you could ask me for control.
Yes, sir, I'm requesting control. I've requested it, sir.
So you can use the vertical scrolls, arrows, and your history is it's a 75-year-old female with an acute onset of abdominal pain and distension.
Okay. So just give me a sec.
Take your time and no problem.
I don't know why it's not scrolling. Yes, it is started.
It-
Sir, I would like to
Yes.
start from the beginning. So this is contrast enhanced CT abdomen in a 70 years old female patient, in which I would like to take a moment to scroll through entire check. Okay, sir, I would like to start the case now. This is in this axial contrast enhanced CT abdomen in an adult patient. I can appreciate that there is portal venous gas. There is adjacent to liver. There is. I can also appreciate ascites. The gas is portal venous because mostly it is branching in pattern and it is reaching till the periphery of the liver, and moreover, it is less common, less concentrated within the central part of the abdomen. The gallbladder is a bit distended, with might be sludge or fluid. There's some heterogeneity seen within the porta hepatic region, and there is distension of abdomen as well. In the region of there is extensive calcification with a filling defect seen in the region of superior mesenteric artery, I think, and there is some distortion adjacent to it as well. There's an air focus adjacent to it, which is I would like to follow this. Mm, yes, this is a thrombus which is propagating within the branches of SMA. I can also appreciate that there is pneumatosis intestinalis, a bunch of bowel loops on the left side of the abdomen. They are distended with pneumatosis and with less enhancement of the wall. There is, and also somewhere in the in the along the right eyelid blade. I believe that this is all small bowel, and if there is misty mesentery, somewhat hazy mesentery seen, I cannot appreciate any surgical clips here. There is a calcification seen in the lower part of the abdomen. I think they could be calcified fibroid, or they don't. There's also diverticular disease in the sigmoid. So compiling all my findings, sir, in my routine practice, I would like to see the lung window to rule out any perforation as well.
Okay. So, what's your diagnosis and what would you like to do with this patient?
Sir, my diagnosis is that this patient has acute superior mesenteric artery thrombosis, which has led to some gangrene of the bowel, and there is distortion of the adjacent anatomy, I can say. I don't
Yeah.
know. Maybe this is due to uh, any previous surgery, or I don't know, that there's some teething type of appearance.
All
And
right.
I would also like to take the history of if any previous surgery or something. But currently,
Yes,
what
there was
needs to be.
history of previous surgery of pancreatic tumor resection. Yes.
Okay,
And
so
so,
might be that is the reason that there is
and
hypodensity. Sir, I would like to take the review of the notes, that what was the surgery? Was it complete removal? Because there is a hypodensity adjacent to it, there might be possibility of some recurrence.
now what
So,
you will do in this particular situation, this case comes to you in duty room. The patient is in severe pain. What
sir,
is the first
urgently,
step you need to do?
sir,
Yeah.
urgently, there should be laparotomy, immediate laparotomy to take out the gangrena segment and relief of the immediate thrombus, and removal of the gangrenous part of the bowel. Then second step should be restaging and comparison with the previous, what part was removed, whether it was complete or partial removal, and what should next be done, restaging or whatever, to rule out that whether there is recurrence or is it due to some fibrotic changes which has led to the thrombus. And so firstly, I would immediately convey the findings to the surgery team on call to see the to let the patient go for laparotomy.
Perfect. All right. So now I'm changing the strategy a bit. I will take case by case and will explain you so that every case you will learn something and you will improve in the next case rather than just going straight ahead to the next case. So yeah, what you did well in this case and what you can improve, both things we can discuss over here. You very well structured your, the findings. You picked up the emergency finding, the urgent finding. That was perfectly spotted. The diagnosis here is absolutely correct. That is the superior mesenteric artery occlusion, secondary to some lesion, which you have already stated. So you picked up the findings nicely. You raised the concern for ischemia. You also mentioned the other ischemic findings, supportive findings. So everything was fine. And you also correlated with the previous image. These things are very important. Now, what could have been improved? That thing was you have wasted time in speaking everything. Now you got the thing. Every case has made of two things. Always remember, guys. Either there may be a safety finding or and associated another finding which may be indicating the etiology or maybe the complication. So just focus on that. Once you got it, you understand the process, why it has happened. So first you have given the observation, 2 3 points, then also pertinent negatives that there is perforation or not, or you are concerned about it. Then you come to the interpretation. Okay, I think that there can be an ischemia, and that is because of this reason there may be chances of occlusion. And the third point would be once you given the interpretation, your diagnosis is there. First, you have to be safe doctor and you have to manage this patient immediately. So rather than saying laparotomy or something, you will say that as per your role, because that you are not going to decide, that clinician will be deciding. So you say that I will immediately pick up the phone and inform the emergency doctor that and discuss with their consultant that these are the findings and this patient requires urgent surgical referral, surgical pathway referral, and urgent vascular pathway referral for the further management. That's all. That's where your job stops. Okay, you have diverted patient towards from its clinical question towards the clinical pathway. That you have to do, and that's what examiner wanted to listen. So I will give you a demo answer for this so that you would be able to understand. If I would be you, what are my findings? Okay, so yeah, I'm looking at the case, I'm scrolling it. The clinical question is severe abdominal pain. I'm looking at the findings towards severe abdominal pain. I can see that there is a portal venous gas, or uh, the branching pattern of the gas, and then I can again see that there is a pneumobilia or whatever, and then I can check that there is a occlusion of superior mesenteric artery, and I can see that there are some bowel loops which are showing decrease enhancement in the jejunal loop, also some bowel loop in the region of the ascending colon, which are also showing decrease enhancement over here in this region. Differential enhancement pattern is seen. So my finding is, my interpretation is, there is SMA occlusion and there is a ischemia of the bowel, which is emergency finding. Now I'm looking at the cause. The possible cause would be the soft tissue surrounding the superior mesenteric artery. I would like to correlate with the previous films to ascertain the etiology. There may be a previous surgery or there may be some mass lesion which is growing on. But at present, I will immediately pick up the call and inform my finding to the referring doctor to arrange the urgent surgical review for this patient as well as urgent vascular review to save the life. That's all. You're getting my point,
Yes,
how
sir.
the
Please.
difference happens, yeah? So you are
Yes.
absolutely nice, but what the thing happen is you have limited amount of time, just 15 minutes. If you
Mm,
waste more time in the case, if you speak everything, they will mark you good only, but you may be having less number of cases. So on the first case, you were very nice. You did describe everything well, but again, the management part should be pediatric orthopedic review and discussion with the consultant with a view to arrange a further MRI, something like that,
sir,
because you
sir,
have to
please,
discuss. Sorry?
please repeat again. Please repeat
Yeah.
again.
So it will be, the management would be. So diagnosis was absolutely right. Again, I am repeating the diagnosis. It was the right-sided avascular necrosis, also known as Perthes disease. Every finding was correct. There was a sclerosis of the femoral head, decreased size of it, femoral epiphysis, everything was fine. All right. And you should say that there was no any gas, there is no fever in terms of clinical questions. So pertinent two negatives you have mentioned. After that, you say that I think that there must be avascular process going on. My diagnosis is avascular necrosis. In this case, this is an urgent finding. I will flag this finding and I will inform this finding to the referring consultant, especially if it comes from the GP, I will inform GP or else the referring consultant. So they will say from where the case is referred from. If it is from orthopedics, I will ask them to review with the pediatric orthopedician. Okay, so you will
Mm,
say that I would like to manage this patient by, or I would like to arrange a pediatric orthopedic review,
mm,
and also would like to discuss about the further MRI to detect any opposite side processes going on or not. That's all. Only
mm,
two steps. You are not going to say what is the actual management or what is the surgical management. Your role is
mm,
from clinical question to clinical pathway. And whenever there is emergency, you need to say that, yeah, this is emergency. I will act immediately. That's all. Now you're getting what is the difference and how the UK process works, right?
Yes, sir. Okay, sir. Mm.
So we'll go ahead with the next case, and I want that kind of improvement in it. So this is the next case, and this is your fill.
Okay. This is
This is, I will give you a bit of clinical history for this patient. This is
mm,
a kind of newborn patient, and which is having crying and failure to thrive, something like that. Just recently born patient, 15, 30 days. Please go ahead.
okay. This is X-ray abdomen frontal projection in a 15 days old neonate patient. in which the first thing which I can appreciate